honor to share this moderation of this webinar with the European Society President, Eleftherios Tsiridis. Hello, Eleftherios.
Hello. Hi. Hi, everybody. Thank you, Oliver. Thank you for the very kind introduction. It's a great pleasure and honor to have that's a wonderful crew today with all these great speakers. Thank you, everybody, for participating.
So we have, Eleftherios, many, as you mentioned, interesting speakers here from all around the world. So, Eleftherios, can you tell us something about that?
The event today has got two sessions. One, we have the first session, which I'm going to moderate, and the second one, which is a crossfire with case presentation. So, in the first part, I have the pleasure and the honor to introduce three distinguished lecturers. The first of all, a great friend of mine, Jay Parvizi, needs very little introduction. Everybody knows Jay is a professor of orthopedics now at the Acıbadem University in Istanbul, Turkey, and emeritus professor of Thomas Jefferson and Rothman Institute, Philadelphia. He's the co-founder of the International Joint Center in Istanbul and co-founder of the International Consensus Group. A few weeks ago, we were together in Istanbul. He organized a humongous meeting, the consensus meeting there, and he is coming first to us for the recommendations from this meeting about infection in primary total hip arthroplasty. Jay, thank you very much. Always a pleasure and the honor to have you.
Thank you so much, Eleftherios, and congratulations on your presidency. And what an incredible leader you are. And thank you for your friendship, and thank you for everything you do for our profession. It's an honor for me to be on this webinar with an incredible group of people. And I've been given 8 minutes to cover the summary of what happened in the International Consensus meeting. As you all know, International Consensus Group is a nonprofit organization whose mission is to engage experts from around the world to create compendium up-to-date recommendations related to various fields. This is a process that usually takes about 2 to 3 years. And this meeting, the third meeting that we held in Istanbul on May 8th to 10th, was no exception. This time it was a little different. We performed systematic reviews and meta-analyses on each question that was assigned. We assigned 8 to 10 delegates that were experts in that particular field, and then these delegates then created the document. The process was done to agree on things that we know, agree on things that we don't know, and then decide what we need to do to know more. But you might say, why bother? Well, first of all, because literature is not definitive on many issues, and many of the things we do today is really based on very little science. And to try to create science, especially related in the field of infection, unfortunately takes a huge amount of effort. Now, of course, that's not that's not to say we don't need to engage in creating evidence. However, if you look at some of the studies, these are incredibly difficult to do. I think we should all congratulate Tom Ferring for conducting one of the most critical studies of 1-stage versus 2-stage, which is shortly to be published in the US. That took about 4 to 5 years to conduct. And if it wasn't for Tom's leadership, I don't think this could have ever been done. We're running a study right now, oral versus intravenous antibiotics. This is a follow-up study of the OVIVA trial that was done in Oxford. It's taken us almost 2.5 years to recruit 67 patients, and we need 350. The 1 versus 3 dose of antibiotics that Thorsten Saylor from Duke is doing has also been going for almost 3 years, and there's probably another 3 years to go before we know the results. So why am I telling you this? I'm telling you this because I think we need to get together and decide on what is the evidence related to these questions at the moment, and to try to come up with recommendations until we create further evidence. And we selected all these questions out of 2,000, and some of these are very interesting for you to perhaps to know. Obviously, out of the 350 questions covered, 8 minutes doesn't give me enough time to tell you about everything, but let me give you a snippet of some of the exciting stuff. Is there a genetic predisposition to SSI and PJI? This was done by Nate Heckman's group, and the answer was yes, there is, and a very strong agreement, about 90% agreement, that there is a genetic predisposition. Is there a role for gut microbiome? This was a study that was again done by experts who published on the subject, and again appeared that with 82% agreement, people feel that gut microbiome does play a role in causing SSI and PJI. I think in the future, as we see more and more of these resistant organisms, we'll be seeing more of the bacteriophages. Here is the world's experts on bacteriophage, including Tristan Ferry and Gina Su from Mayo Clinic, who've conducted many of the studies related to phage. And the agreement was, yes, there is a role for phage in the future. Should saline be injected into a hip when we deal with the dry tap? It was a study that was again done by these delegates, 90% agreement that there is really little role for injecting saline into a joint in the cases of dry tap. How long should cultures be held? This is a very important question that I think we feel on a daily basis and also have issues related to it. You hold it too long, you will isolate organisms that may not be true pathogens. You don't hold it long enough, you miss the pathogen and have a high rate of culture negative. So here it was 14 days was the agreement that, again, many of the infectious disease doctors that served on this particular question recommended with a very high agreement. What is the optimal duration for holding cultures? Again, culture samples should be obtained from, during revision surgery, you should obtain culture samples from every patient undergoing aseptic revisions. Molecular techniques was described. This was Pierre Randelli's work that brought all the group together, and 92 agreement that there is a role for molecular techniques in the future. Should we aspirate the joints prior to reimplantation? 86% agreement that we should make every effort to try to aspirate the joint prior to reimplantation. This question was discussed with somewhat passionately, and here are the indications for performing DARE that was produced again by Jimmy Cashman and for the rest of the group. How about, is there a role for arthroscopy doing DARE? Except in rare palliative cases, arthroscopy should not be used for performing DARE. And finally, this is very interesting and actually somewhat surprising, the one-stage exchange, and thanks to people like Faris and others have published on this issue, and they won, again, the INFORM trial as well as the Tom Fering's work. Now we've come to realize that there is a real role for performing one-stage exchange, at least for a larger group of patients than we had considered in the past. So this was Shaoli's group from China that they talked about one-stage, and 92% agreement that there was a role for one-stage exchange. Finally, as you all know, in US, we have moved towards giving 7 days of oral antibiotics to people. And here's actually David Liu from Meneghini's group that actually was assigned to do this question with a group of other experts. And the agreement was during the consensus that there is no role for extended oral antibiotics, neither in the outpatient setting nor in patients undergoing primary total joint arthroplasty. So hopefully, again, 94% agreement during the consensus. But not everything reached consensus. Intraosseous administration, this was Mark Spengel's work, and people like Simon Young served on this delegate group, but for some reason there was little agreement that intraosseous administration of antibiotics has a role in management of SSI and PJI. And intra-articular delivery antibiotic was another one of those that didn't reach much of a consensus. But there were others in terms of there is no need for 2-week antibiotic holiday, and that's based on little to no science. So it looked like people enjoyed the new format of ICM, and it looks like people did learn, including myself, from this process. And I want to thank you, many of you on this webinar were delegates that attended the meeting, and I want to thank you all for being there. The documents on icmortho.org and will be shortly published in the Journal of Arthroplasty. Thank you very much.
Amazing, Jay. Fantastic presentation. Probably too short to present everything that we discussed in Istanbul. So here is my invitation for the next webinar, 26th of June, to present details of the consensus meeting in revision total hip. So this is my invitation for you, and you will have another 8 minutes to present only about revision. Do you agree with that?
Can't wait. Yes, okay. Thank you. Thank you so much again.
Thank you, Jay. Eleftherios, please.
Yeah, thank you, Jay. Wonderful presentation. Amazing work. Amazing work. Thank you for your contribution. So now we're moving on to Miss Tross, Samantha Tross. Samantha, nice to digitally meet you. I went through your credentials and your CV and your current position. You're a consultant orthopedic surgeon. Samantha is a graduate from UCL Medical School, fellowship trained in Toronto and Sydney, and he's the first female Afro-Caribbean orthopedic consultant in the UK. How amazing! Of course, she's practicing joint reconstruction. He's going to talk to us about the new technologies to improve preoperative planning. Samantha, thank you very much for your contribution to this webinar. Thank you.
Thank you, gentlemen. Thank you very much for the invitation. Delighted to be here. New slide, please. Next slide. Currently, the most common form of templating is 2D digital templating, which has its uses, but things have advanced. New technologies available are 3D preoperative planning, artificial intelligence planning systems, robotic assisted systems, virtual and augmented reality technology, and virtual preoperative pathway streamlining technology, all of which I'll talk about in more detail. Next slide, please. The 3D preoperative planning software enables the surgeon to visualize the whole pelvis and to plan this procedure. By doing so and having a 360 view, it improves their accuracy and hence reduces complications. Next slide, please. The 3D model is generated based on CT scans and other imaging. And the importance of this 3D planning is that this is a surgeon who makes the decision where to best place the implant to prevent things like dislocation, impingement, leg length discrepancy. Next slide, please. In terms of its accuracy, it's very good at predicting the size of the implant and also things like offset and leg length planning. It can be accurate up to the actual ideal size of the implant, though it's not foolproof, and sometimes the size is 1 or 2 sizes outside. And differences occur when there are abnormalities such as the developmental dysplasia of the hip. However, 2D templating still has its uses. It's very good, and it can predict size of implants also, but generally tends to be 1 size or more outside. However, the accuracy, I think it's still worthwhile using that if that's all you have available. Next slide, please. With the artificial intelligence planning system, it's quite similar to the 3D planning. You still get a 3D view of the pelvis, again, from MRI scans, CT scans, etc. But in this system, it's the actual computer, the database that tells you where to place the implant. So the onus is taken away from the surgeon, although surgical expertise still comes in, but it can then reliably tell you where to place the implant. And on top of that, it has such a next slide, please. It has a wide database, so it can actually predict patterns and predict outcomes. And in this way, it can reduce the variability, because with the 3D planning, it's really based on the surgeon's expertise. Expertise required here too, but it can also help improve the precision. Next slide, please. Studies have shown that the AI planning tool is more sophisticated than just pure 3D planning. But there are studies that have shown, for example, this one here I've highlighted, that the two are very similar in terms of the AI and the 3D software. But what we do know is that both of them are superior to 2D templating. Next slide, please. This is the sort of imagery that you would get from these 3D models. And you can really, as I say, get a full visualization of the pelvis and the femur and see where your implant will sit within it, and then try to recreate that during the surgical procedure. Next slide, please. Again, this is just showing you that it's not foolproof, that whilst it may gauge the size perfectly, and this can be important in areas where there isn't the availability of a wide set of implants and you need to scale down what you purchase, then this can be of some benefit to you.
Excuse me, we can't hear you, Samantha.
Have you lost me?
Yeah, we lost you for a minute, but you're back.
Sorry.
Oh.
So apologies. Robotic assisted systems, such as the Mako and the Rosa, also enables the surgeon to achieve accuracy and reproducibility. Next slide, please. Again, it requires information that's taken from CT scans or MRI scans, and can help determine the position for the implant and the best alignment. Then you have a robotic arm that helps guide the precision for the implant placement. The important thing with these systems is that it relies on the information that's input. And so it's not, again, foolproof, and we have to make sure that the data is accurate and the surgeon is adequately trained so they can recognize when things are not as they should be. However, it does give real-time feedback on implant position and alignment. Next slide, please. There are many studies that support that it's a very useful tool, but however, the long-term benefits of the robotic system is not yet proven. We know that you get better implant alignment, positioning, etc., but whether this will lead to long-term longevity of the implant, that's yet to be seen, and of course it is costly. Next slide, please. In terms of virtual reality systems, this is where a surgeon is actually transported from the normal environment into a simulated environment, and that is done via use of a headset, and it allows the surgeon to actually go through the steps of the procedure and understand the complex anatomy, and it is an excellent training tool. And so in this way, it can help reduce any variation during surgery. Next slide, please. The difference between the virtual and augmented realities: in augmented reality systems, the surgeon remains in the real world, but you have an overlay of information which enhances their perception of the physical environment. And that's achieved via smartphones, tablets, and as well as headsets. Next slide, please. Lots of studies again, but not a huge amount of studies, but there are a few studies that show the benefit. And when this was used with a group of medical students, and they were trained to put an implant into the pelvis, they had two groups, one being trained by an experienced surgeon, the other using this augmented software, and we found there was no difference between the two groups. And this shows that this may become a very useful tool in training when there may be reduction of expertise available. But certainly, even the students felt that having the combination of the software and the surgical expertise was important. But we can see that they can become potentially very useful in our training. Next slide, please. Finally, we have to think about the steps leading up to the surgery. But using virtual healthcare technology, we can have telemedicine, we can reach patients in remote areas. And in fact, surgeons who are in remote areas can also gain assistance with someone more experienced. It can help streamline the pathway because it can look at clinical times, etc. It can also make sure that you can assess equipment that's available, consumables, and make sure that that's available for surgery so that can reduce your delays and your cancellations. Next slide, please. So in summary, I think these tools that are now available are very useful, but they can be costly. They are not 100% they're not foolproof. There may be some increased training time required to use them, and we don't have any long-term data on the benefit. But they certainly are proven to improve the accuracy and precision of the implants. They allow individualized treatment of patients, and they can support preoperative purchasing of equipment. And I think they'll be a very useful tool for the future. Thank you very much.
Well, thank you very much, Samantha. Great talk. And I think it will stimulate a lot of discussion. And now we're moving on to Fatih Kucukdurmaz, professor from Istanbul, the İstinye University. Fatih is a great friend. We've been working on several projects. He's a graduate from Marmara University and fellowship trained in Rothman Institute in Philadelphia. So he's going to talk to us about the new designs and the potentially best bearings in primary THA. Thank you, Fatih.
Thank you, sir. It's an honor for me to be here as a panelist, and thank you for invitation. So this is the new designs and the best bearings is a really very wide topic that it's impossible to talk about every single new developments in here. But I'm going to emphasize the most prominent ones. But before that, let's talk about why do we need better designs first. So still we have need to improve the bone preservation. That's an issue. Still, that's an issue, and achieve more physiological load transfer. The implants that we put into the bone does not like a natural pattern of behavior for load transfer. So it is still open to developments, and less invasive techniques should be available for the new designs, and it should improve the implant stability also. And in turn, long-term outcomes while addressing the complications. So there are a lot of designs until now, and they have different properties. I'm going to, sorry, yeah, okay. So we know the traditional classifications. So there are cylindrical full post-coated stems. They are often, they're all porous coated materials. They have specific indications, not good for routine use. Tapered stems are more popular, and they have different in length based on the indication. You can select different length implants. However, still there is some issues that needs to be developed in here, and rectangular cross-section stems are also used to be popular, and nowadays it's used for more specific indications, such as like dysplastic patients with an osteotomy. In many clinics, it's used for this purpose, or some specific indications addressing the femoral deformities. Shorter stems, neck-preserving stems are recently more popular. However, still there is issues about that I'm going to emphasize in the coming slides. So overall, if you look at the clinical outcomes, the most popular ones are the tapered stems for routine use. But there are some things that we have to emphasize at this point, because the designs are developing in this way. The metaphysical filling stems have better outcomes. And in this regard, the triple taper metaphysical filling designs looks like a better long-term outcome. So if you look at the tapers, the single taper, double tapers, and the triple taper stems are available. And the metaphysical filling in here has the best outcome in terms of the clinical studies. Also, biomechanically and the finite element studies show that the load transfer is best with this type of designs. Because at this design, the initial mechanical fixation is at the distal half of the porous coated part of the stem, and also it is in direct contact with the medial calcar, which is important for the load transfer. And then distally, all the way to the metaphysial, there are medial and lateral contacts, which also helps in turn to transfer the load. But we know that there are shorter stems, and there is a drive for surgeons to use a shorter stems in daily basis. The reason for that is it allows to put these implants in a minimally invasive way, and the proximal porous part gives the enough osseointegration for those implants. So there are some biomechanical studies showing that, as you see in here, the distal part does not give a much contribution to the stability of the implant. So if that part is shortened, then still biomechanically the implant looks stable, and also biologically it allows to make a osseointegration. There are some other studies done biomechanically showing that the shorter implants are stable enough, except if the bone quality is poor. If the bone quality is good, the shorter stems are enough biomechanically, and load transfer looks much closer to the natural load transfer. However, if the bone quality is not good, like type C, door type C, medulla is there, the longer, standard stems are better to use. But more than that, there are very short, or there are different terminologies for this, metaphyseal short stems or ultra short stems. They look very attractive, but there are some potential downsides of these implants, including the technical sensitivity and patient selection limitations has to be taken into consideration. And there are limited long-term data. So if the patient is selected well, and if the patient is, let's say, young, if the bone quality is good, and if technically you're experienced, there's a learning curve in here, if you can make a precise surgical surgery, then they might be good, but in daily basis, still they are not recommended to use. When we're talking about the new technologies, of course, we have to talk about the custom 3D implants. They are produced first with the CT scans, and processing that CT scans, we have a 3D bone models. And then with that 3D bone models, we can produce a custom-made implant. But there are some disadvantages because it's time-consuming, it's more expensive, and there is a limited evidence about that, and long-term evidence is not there yet. But it may have some specific indications for a certain group of patients. It looks advantageous compared to the traditional stems, but in daily basis, it is not feasible. I would like to show you and photos from my office. I have a 3D printer in my office, and I do not produce implants, but the 3D technologies are improving. I put these photos to emphasize that it's much more accessible than before. And I used to model and produce models for some complex cases. These are not complex ones, but in order to understand in a 3D fashion with the physical bone structure, I print them out and then make the preoperative planning. About the new technologies, I have to talk about the changing paradigm about the coating. This is an interesting topic because the surface coating has always been a very hot debate, but now the paradigm is changing through another way, and the functional grade materials are coming to the scene, because the traditional surface coatings has still some concerns about the interface stress, shear stress, and some still has some issues about the osseointegration. But now the function graded materials are about to be in the markets. There are many studies about that. Still, they are experimental phase, but they're going to be in the market pretty soon. So what is function graded materials are? It's a gradual change of the material from one side, from the core to the periphery, or from one part of the implant to the other. There's a gradual change. As you can see in here, is a very simple illustration. It starts as a metal through the ceramic. So there is a transition region, and gradually it changed from one material to the other. So it looks more physiological. So it can be arranged in a way that the interface between bone and the implant can be selected from one material, but the core can be from another material. So when you compare the traditional stems and the porous materials, that full porous, not porous coated, it's a full porous stems. The traditional stems has a solid metal structure, which is not very compatible with the natural bone models. However, on the other hand, at the other side, you see the porous structures, and the porous structures can be graded in different directions. There are different optimization ways for the porosity, and at the end, the stress shielding and the bone resorption in experimental models is much less in this in this type of these stems and implants. About the bearing surface, I will be very quick in this, because we know that there are different couplings in here, and with different materials, they have different characteristics, hard on soft or hard on hard. We know all these discussions, but when we come to the new developments of the materials, we have to first look at the reason of the problem. So always the end of bearing surfaces, there is materials coming out due to the wear.
Yeah, go to the end, please.
Okay, so the new materials are working in this way. We think that the contact surfaces are perfect, but it's not actually. They're always a partial touch, so the contour body and the body has always irregular rough surfaces. The untextured materials are like rough, but laser texture technique has some different texturing technology. It textures the polyethylene, then that dimples there acts as a lubricant reservoir, and in this way it captures the wear debris, and also it increases lubrication. So these are the one of the most common, most prominent technologies is going to be available. The last one is the fine particle shot peening. This is different from the grid blasting, but looks like that. The spherical nanoparticles are bombarded to the material, makes its surface hardened, and it allows again the lubricant capturing on its surface, and it make the reduction of the coefficient of friction a lot. So there are different materials on the market nowadays. There are many studies with different materials, but in conclusion, there are challenges in the adoption due to the cost and regulatory regulations. But in future, we have a lot of different surfaces, bearing surfaces and materials and designs available. So thank you. I'm sorry. I think I am a little.
Yeah.
Great presentation, Fatih. Great. Now we're moving on to discussion, and we can take it one by one. So Jay, wonderful presentation. And do we have any questions in the chat section? Probably not yet, but let's go fast and ask the, I mean, out of your summary, I have to summarize what I saw as a potential future. So gut microbiome. What is the future of the gut microbiome? I mean, you've got a theory. You have presented this theory. You've got data. You may share with us your own data, and then we move on to phage therapy, which is the future therapy. But let's talk a little bit about the gut microbiome. What is this business?
Yeah, sure. Thank you, Eleftherios. That's a very exciting area, and I think orthopedics is a little behind compared to other subspecialties, but we're catching up. Some of the great investigators are publishing work on this. Basically, the bottom line is that these organisms that cause infection, in about 80 to 85% of the time, they're coming from patients' own microbiome. Either the skin, the nose, gut, or even the joint itself, not the joint, spine, any places where we do surgery appears to have a distinct microbiome. So the translocation story is really exciting and interesting, and it seems like there may be a role for us to try to enhance the patient's immune system by preventing translocation from the GI tract that plays a major role. What is really fascinating, and I think that could put all of us out of business, is if gut microbiome is proven to cause these chronic musculoskeletal conditions in the first place, and there is some signal that suggests that might be the case. So fascinating subject. I think we're just scratching the surface. But if we don't keep our eyes on this and get involved, we could have our lunch stolen by somebody else.
Yeah, that's very important. I mean, is anybody else who would like to mention that? I mean, we know that the gut microbiome is involved also in mental health and other conditions as well. So probably things are changing, our targets are changing. So any other comments from the speakers or anybody else? I mean, any experiences from the literature or something?
You know, since you mentioned, I'm sorry, I don't mean to monopolize the discussion time, but a recent study came out of Harvard showed that intractable depression is caused by an organism called Morganella morganelli, and it causes a reaction, an immune reaction that leads to the release of a chemical called EDT that affects the brain. And in these patients, alteration and reduction in the number of Morganelli resulted in incredible recovery for these patients. So it's a fascinating subject, and I think we really need to keep our eyes on these new developments. I'm sorry, I didn't mean to stop, but that's fascinating.
Fatih.
Yeah, it's exciting to listen again about this, but I would like to ask, is there any part which is sterile? This is the first question I would like to listen. That would be so interesting to hear that there's no place sterile first, and also about the microbiome of the like intestines are like makes sense, but what about the other parts of the door? For example, skin microbiome, let me say, or in any other place, viscera in the body may have some flora which may affect in this sense?
Yeah, Fatih, that's a fascinating question. The answer is probably there isn't a sterile site in the body. The more and more we are reading papers in Nature, Science, and other journals, high scientific journals, appears that there is a distinct microbiome in everywhere, and joints included. So no sterile site. The question you ask, skin microbiome is fascinating. I mean, Dustin Long's work from University of Washington shows there's an anatomical gradient, like C-spine gets infected by organisms that resemble the oral cavity, and L-spine gets infected by, anal cavity cells. So and the skin microbiome of one person versus the other is very different. I know most people know this, but if you don't, you should be following the Human Microbiome Project that was launched at the NIH back in 2007 and is now entered phase 2. Fascinating stuff getting published in highly scientific journals. And I think some of these have implications. I mean, you probably see my publications, cartoons from Nature and Science that shows osteoarthritis could potentially be caused by a change in microbiome or dysbiosis. So I'm fascinated, and I believe that we will be doing different things in the future.
So Jay, you are telling that the new consensus changed a little bit our mind about infection in orthopedics. That means that we had to focus in the patient microbiome more than other issues to prevent infection. That's what you mean?
Yeah, absolutely. I mean, I didn't show it to you, like personal protection system. These helmets we're wearing, you saw that. Gary Hooper presented that. 92% agreement that plays no role in prevention of infection. So instead of throwing our money at things that make no difference, we should be concentrating on things that do make a difference. The reason we haven't made a difference to SSI rates over the last 2 decades is because we've been barking up the wrong tree. We've been spending millions of dollars designing operating rooms when we're ignoring the skin microbiome that Fatih just mentioned.
And by the way, give us a little bit of insight about the phage therapy. What is the story?
Yeah, so Gina Su presented that, and Gina Su, Tristan Ferry, those are like the world experts in musculoskeletal phage, as you know, and licensed. Phages have been around for a long time. It's a 1915 discovery, but it went away with the discovery of penicillin and antibiotics, and is not coming back. So you can use phages particularly to treat multi-resistant organisms when you have no antibiotics and no way of treating them. I've treated 3 patients myself with great results. Gina Su presented some of her work. So phages, as we're running out of antibiotics, and as the pharmaceutical industry is not indulging or involving antibiotic development anymore for understandable reasons, I think we're going to be seeing more and more of employing phages as well as license. Horizon grant, we're just writing a Horizon grant, $15 million that Europeans are throwing into discovery, into evaluation of phages for treatment of musculoskeletal disorders. So we're running out of antibiotics, we're running out of treatment choices, and phages appear to play a very, very important role.
So just in one line for the report of your presentation, so immune system and immune system manipulation may be the future of infection in human beings. 100%. Thank you very much, Jay. Now we're moving on to Samantha. Samantha, what's a fascinating presentation. Let's go to artificial intelligence. I mean, how can you imagine your robotic system is going to evolve in the years to come? Do you think you're going to have a kind of an advisor to tell you what to do, and where these data are going to come from?
I mean, this is a problem. I mean, the data is going to be generated from what's already out there, and of course, some of that data is biased. But I think that despite that, the wealth of information out there can be useful. It doesn't eliminate the knowledge and experience of the surgeon, however. But I think that at least being able to be guided. And if patterns can be predicted, so we know, look, if you have this particular disease pathology, these are the potential pitfalls. You can plan better, you can advise a patient better. So I think it's going to be tremendously useful. So,
Samantha, fantastic presentation. Actually, as you know, there are many robots in the market. Everybody
yes, lots.
Robots. So, but you have presented something that is interesting: the augmented reality and mixed reality. Do you think the mixed reality will change our current surgical practice? I mean, don't use robot, but mixed reality, the position of the components and everything. We don't need any tool, extra tool or logistic, just with the mixed reality. Do you think they will come in the next years?
I think we will reach a stage where we're using all of these systems because all of them have their potential benefits. I think that sort of the augmented reality, certainly, I've not had any personal experience of using this, but I can see the benefits potentially. And I think that I don't think I can stand in this moment and say one system is going to be better than the other. I think there are benefits from all of those, and it'll come down to cost and availability.
So, Eleftherios, there is a question.
I think the virtual reality, the augmented reality is sort of part of the same story. It's a more educational tool rather than, I think everything is going to be absorbed by the robotic capability of predicting and feeding back the data and probably proposing. I think Samantha elaborated on that at the end of her discussion, saying that you can educate your robotic system somehow, and the robotic system can come up with ideas not only for the templating, but actually positioning your components. Is it correct, Samantha?
That's correct. That's correct.
Yeah.
That's
where we're heading.
There's a question, Eleftherios. There's a question from the audience.
Yeah,
but Janatos is asking about the 3D printing. So Samantha, 3D printing, or maybe Fatih, I mean, do you think, what's the role of 3D printing actually?
I mean, I'll just quickly go in before Fatih. I mean, I think essentially, because if you can actually have the model right in your hands and you can move it around and touch it and so on, and then really look and see where your implant best fits, I think that will optimize your precision during the surgical procedure. But again, I haven't actually done any 3D printing, so maybe Fatih can talk about his experience on that.
So about the 3D printing manufacturing, it's not feasible yet. It looks like it's a little time consuming and it's expensive for now. So it may be used for some special circumstances, which is already used. But as I showed in my presentation, I use it for my personal practice. For some complex cases, it's difficult to understand the anatomy or making a preoperative planning. It's very easy to make a printing. I learned some software for sure, but which is very easy and user-friendly. So you can use it in your office and look at the bone and make a good planning. So that is very easy, very accessible, cheap, and like it's really worth it to do that for some complex cases.
Well, there's a little battle between Fatih and Samantha here. Samantha is actually promoting the robotic technology. So I guess, which I believe as well personally, that we're moving to the functioning or functional positioning of the components, regardless the material. And Fatih is presenting the functionally graded material. It's a new concept. Elaborate on that, Fatih. I mean, is this going to, I mean, this is a kind of bonding thing. It's
Yes.
not about functioning. I mean, but is it the bonding? Do we have problems with the bonding?
That's a term in engineering for sure, like the functional graded materials. Probably it's coming from this production or manufacturing process. But it looks very promising technology because you can like design the implant in a way that with a different young modulus in different parts, from starting from the core through the surface of the implant. There is different porosities or different materials, and the interface and the core may be from different materials, so it will be more like load transfer, and the osseointegration problem will be much less with those implants. And the modulus of the implant can be designed based on the bone quality, but it's not like a technology for a custom designing.
Okay, let's try to land back in onto the Earth's surface. We're actually flying too high up. So cemented shorter stems is a future for cemented shorter stems, Fatih. I can see there is a trend to go back to cemented implants because cement is good for osteoporotic bone, and we should not forget that. Now, whether we need to shorten the stem or not, it's a question. If we ask the extra people, they say yes, no problem at all. They have the short version of the extra stem. So, any data on that front?
Yeah, the shorter cemented stems outcomes are good.
A little bit better than the
better. It's a little bit better than the traditional ones. I personally do not have experience with the cemented stems in daily basis, but according to literature, it looks like the shortened cemented stems have good outcome compared to the traditional ones.
The chairman is pushing me to stop the discussion somewhere here, isn't it, Oliver?
Yeah, I'm sorry, guys. It's an amazing discussion, but we don't have enough time for this fantastic, and we will have to continue with the next part of our webinar. That is a crossfire. I mean, about new technologies as well. We are going to talk about the robot in primary total hip. Are you sure to use it? So we have two fantastic speakers, Eleftherios. So we have Fares and we have Olga. Fares is in favor of robotics in our primaries, and Olga is against. So at the end of this discussion, I mean, all the audience should vote the winner. So please keep there and be ready to vote for the best presentation who convinced you to do in our primary. So Fares, please go ahead.
Oliver, thank you, and what a great webinar so far. So hopefully this adds a little bit to the debate, and Samantha's already set the scene for everybody about robots. I should, of course, start by sharing my disclosures because they are incredibly relevant here. This is an area that industry is very interested in. There are a whole load of robots out there, and we've killed off the past generation of robots with the systematic reviews that said they didn't work, and we've now got a modern generation that seem to be working very, very well. I think that in itself creates some issues because people are very tribal about what implants they like, what industry they like to work with. And in this case, I'm going to talk about the Mako because that's where the real data is in the hip. And that will upset some people because lots of people are very keen on other implants that are not striker based, and these are closed platforms. So there are lots of issues to discuss here, but I think innovation, such as that which you just heard about, largely requires industry partners for us to progress. And in reality, in Europe, we've got much bigger problems with EU MDR that we should talk about another time. Now, of course, we can put joint replacements in without robots, but that completely ignores the direction of travel in everything that we do. We really are shifting towards using computers. And the idea of being able to have a 3D model through a CT scan, to be able to balance, align, and position dynamically during the surgery is very attractive. And of course, there's also a safety element here using robotics. For me, the basic summary slide for everybody is it gives you a new outlook. You plan better, you assess dynamically, you have great precision, and you can choose the right target and deliver that target for your patient. And so you have better options, you'll see some data for better outcomes, and it's a great training tool for the next generation of surgeons to understand what they're planning for and to execute it. And ultimately, I think what we're going to end up with is personalized functional component positioning using this technology for our patients. We've already published a randomized study. The infographic is to your right. Many of you will be familiar with this work, which basically shows that we can hit our target way, way better, whichever way you look at it, whether it's center of rotation, offset, or length, using robotics in a randomized setting in a teaching institution. Now, whether that is clinically significant versus statistical significance is still being assessed in a larger study and in other studies that we're doing in the UK. And of course, it wasn't powered for PROMs. But the real excitement here is that we're starting to understand the spinopelvic relationship. And as we understand the spinopelvic relationship and recognize that different patients impinge in different zones, depending on what's happening with their pelvis from sit to stand and in gait, we start to see the power of modulating stem anteversion. We start to understand the power of offset, and then we can start to plan our hips and evolve them during the operation to get the center of rotation right, to get offset right, and to get the tilt adjusted cup zone so that it is impingement free, as well as getting the right leg length. And that is hugely powerful. How do we do this? We get a pre-op CT, we get sitting and standing radiographs, and then I'll talk you through the workflow. Oliver specifically asked me not to show you the video for time purposes, but basically what we do is we register the femur, we do a femur first approach so that we understand femoral position, femoral version as a primary thing. We can then adjust our socket, making sure the socket is sufficiently covered anteriorly, but also that we're restoring the center of rotation and minimizing impingement, and then we can execute on that basis. And what that gives you is what we call functional positioning, which has been now shown to be very accurate and reproducible. And for those who want more detail, there's a paper that we published on the subject, guiding people as to the technicality of it. And there is good data out there already. Instability is not something we're going to flush out with RCTs, but 2 big US studies have shown a reduction in dislocations if we use Mako robotics. So I think that in itself is quite exciting, because that's a complication we all fear. And then, unlike cavitary surgery, we've started with the simple surgery in orthopedics. But of course, we have complex primaries, we have DDH, we have fusions to take down, and we've got revisions. And in reality, I think that's where robots are going to be huge in the future. Our colleagues in Asia have been able to go off-piste slightly earlier than we could, because their regulatory environment allows that. And it's really interesting to see the burgeoning literature on using 3D planning and robotic arm assistance for the more complex cases. So the promise here is massive. Beyond doing a great primary, beyond using AI to predict, based on our existing 3D plans, execution and outcomes, what should happen to the next patient, to be able to do these horrible cases where you really don't have much knowledge about where to put screws and what size to use will be fantastic. So kind of right now, of course, not everybody has this. Of course, there is for now a cost, although our health economic data, which we're about to present, is really, really interesting. We're just finalizing that study. In reality, for now, in hip arthroplasty surgery, we're making the leap from historical safe zones to functional safe zones. And what we've got is good level 1 data. We've got reasonable big data from the US and other places, basically showing improvements in clinical outcomes. And there's huge potential for reducing instability, pain, and ultimately getting better survivorship. And there are lots of studies on the way. And so this technology is really here to stay. And I think this is something you should all be considering if you have access to it. Thank you very much.
Thank you, Fares. I mean, you convinced me. I mean, that's the situation now. Let's see, Olga, Eleftherios. Do you think Olga will change this vote of the audience?
Depends. There are several criteria that someone can vote in private. However, Fares was very convincing. He's always is because he bases his presentations in extensive background work he does, and we need to commend him on that. He really has pushed the frontiers of robotic technology quite far, and we thank him for that. Now, Olga.
Yeah.
Olga is going to defend the old good surgery. It's not old good surgery, it's a good surgery without technology. However, we can do it using the spinal pelvic evaluation with a sitting, standing position, I guess.
Yeah. Oh, just a second. Sorry, my presentation goes on the back. Sorry, Eleftherios. So I'm very sorry. Can you repeat the question?
Well, it was not a question. It was a comment, and we are eager to listen to your presentation.
Thank you so much. Sorry. So thank you so much, and it's an honor to be part of the webinar series. And I will try to concentrate outline some points about on the side of conventional hip arthroplasty. So recently, when the hip arthroplasty been developed and introduced widely in our practice, we know that there is really advanced technologies to be introduced as cementless to facilitate bone growth. We have nowadays femoral components, modular, which can reproduce the native hip biomechanics, ledger heads, and modern ceramic bearing surfaces. But when the decision to choose between robotic assisted surgery or conventional total, it's multifactorial and mostly guided with the surgeon expertise, because it depends also how many clinical literature, clinical evidence have we, and there also institutional capabilities and infrastructure and resources what we have, and also patient-specific factors such as anatomic comorbidities and the functional demands of our patients. So when we're talking about what Fares taught in the presentation about functional position of the implant, so we assume that with the precise component placement, we can really decrease the rate of the percentage of the dislocation rate. And in such a way, we can cross out this kind of complication of our practice. But nevertheless, so this study which showed that with the robotics we really can decrease this complication, but with the analysis comparing of the surgical approaches which are used, it also been shown that the dislocation rate can be decreased with the usage of the navigation, and also with for the anterior approach, the usage of fluoroscopy really also can be helpful to decrease the amount of this complication. And fluoroscopy nowadays is considered to be a standard of the intraoperative cup positioning. And moreover, for the posterior approach, it's also useful to use robotic to decrease this kind of rates, complication rates, but it's not so significant for the lateral approach. So, okay, and when we take a look on the systemic data and reviews, we also see that the no difference actually in the dislocation rates between these two types of surgeries, and no significant difference in the clinical outcomes and the PROMs, and also no significant difference in major complications between robotics and manual arthroplasty. But we have better acceptable component position with the robotics. Another series of the review also shown the same. There is no significant difference in the PROMs, clinical outcomes, pain relief, but also with the conventional arthroplasty, we had shorter operative time, wherever with the robotics we have potential in a shorter patient stay in a hospital. So one of the points what we are talking today also during the whole webinar is a preoperative planning. And I think it's one of the such crucial points with what we can reach successful outcome for our patient. And it's standardized preoperative planning, what is done in mostly clinics, which is done with the digital templating. With a digital template which allowed us to coordinate, to measure all these parameters, to receive, to make measurement. I'm sorry, computer is stop working. Okay.
Well, no worries. I mean,
sorry. Okay, so
the slides are not working.
Now it's working.
Okay, perfect. Okay,
yeah.
No worries.
But for the robotics, we have to create a patient-specific 3D virtual model of the native hip anatomy, and for that we definitely need to make a computer tomography from the pelvis until knee, and definitely takes quite a lot of time. Hospital resources, rentgenological explosion, and cost, definitely cost. I really agree with Professor Haddad, and in the clinical practice, when we have to deal with the complex cases, and sometimes we're working together with a team, we were thinking, okay, it will be really good to have additional tools will be helpful us to place, for example, the femur in a correct position when we don't have any more natural landmarks where to orientate the stem. So it really would be useful to have something in our tools, in our facility, what can help us to make correct and not to make a mistake, and not to in such way to cause the dislocation, or these cases of the like dysplastic hips, which are also sometimes are really crucial or complex one. In summarize, I can say that the evidence what we have nowadays shows that the really improved radiological outcomes with the robotic arthroplasty, but the functional outcomes are equal between these two types of surgeries. And acceptance of the robotic worldwide is really limited with this facility about the cost, and already exceptional results what we have with the conventional arthroplasty. And that is conventional is well-established track record, cost efficiency, short operative time, and very good long-term outcomes with the best survivorship in 10 years, more than 90%, and 80% in it, more than 80% in 25 years. So thank you so much for your attention.
Amazing, Olga. It's amazing. So probably very balanced, Eleftherios. Let's see what people vote, but we have 5 minutes for the discussion. So it's your time to gain more people voting you, right, Eleftherios?
Well, the people will start thinking, but let's talk business with the two great speakers. Great presentation. Let's talk business now. It strikes me, femur first, and this is a good lesson to learn, isn't it, Faris? I mean, the femur should be done first. This is taught way back from Larry Dorr and other people. Why is that?
Look, it's largely been ignored, and I think if you look at the literature, the literature's been based on the acetabulum, and everyone's talking about this safe zone and analyzing their series and talking about acetabular positioning. But of course, the reality is the femur is important. And unless you know what your femoral version is, then how do you work out your combined version? So I think I'm a real convert to femur first. And I think whether you're doing robotic or doing manual surgery, conventional surgery, you should be thinking about doing the femur first just to understand your femoral configuration. I want to add one other thing. Olga did the usual thing people do when they talk anti-robot, is they reference systematic reviews that include all the old RoboDoc data, particularly the ones from the last decade. Those are dead robots that nobody's ever used, that never showed a benefit. So I think it's really important to, when we're referencing the literature, we reference the literature of the current devices.
True, and it's probably correct as well for the first generation of Mako as well. Now is improving, incorporating now the spinal pelvic and the impingement, most importantly. Now, if you do the femur first, and I think this is a good idea when you're dealing with the uncemented implant, with the cemented implant in the femoral side, you can probably modify a little bit your version, but the uncemented goes where it has to go. And then you play with the socket. So tell us a little bit about this functional positioning of the socket. Elaborate a little bit. So it's a combination of version and impingement and spinal pelvic, all three together?
Yeah, it's all of the above. What you're aiming for is to hit center of rotation, length, and offset in 3D for that patient, whilst incorporating the spinopelvic relationship in order to limit impingement to an absolute minimum. So that plays that in. I couldn't play the video which kind of showed you how to do that, but in principle, you're modifying your implant metrics to limit your impingement. And ultimately, sometimes you'll modify your implants because you'll go to a bigger head or dual mobility because you think there is residual impingement.
But Olga claims also the same, is doing the templating, is using sitting, standing position, is probably classifying. But I would like to ask you, Olga, how do you position your socket? Do you use, for example, the Vidkortik simplified 1AB to AB, and then you give a little bit of version to your socket, or no version at all, or go to dual mobility if you're dealing with a 2B, something like that? How do you do it in your daily practice?
So definitely when we see the patient with this altered spinopelvic relationship, definitely we will go for the standard sitting position for the calculated and making their measurements. Another point, what we do is a really precise positioning of the patient on the operation table, and to use fluoroscopic CR during the surgery, and really correctly checking the position of the cup. So what we're going to do in those tools, what we have in our facility with the operation room.
Radiography is sometimes misleading. I came across to some papers saying that especially in the supine position, especially when we're dealing with a stiff spine, the AP view and the appreciation of the, not the inclination, but the underversion of the socket is not correct. Let's say if it is a fixed standing or fixed sitting position, then how can you actually make use of the C-arm, I mean the actual X-ray?
We operate in a lateral position. The place position on the table on the lateral side, not on the supine one. So it's quite easy to perform the X-rays.
Any comments on that, Faris? Do you trust an X-ray on an abnormal spinopelvic relation?
So no, I think So I think a couple of comments. The first one is, I just hope the next generation of surgeons isn't going to spend their career of 5,000 to 10,000 hip replacements wearing lead all the way through. That's a pretty uncomfortable existence. There is software that compensates for the position. So when we're talking about fluoroscopy, I think pure fluoroscopy is a blunt guide. It's better than nothing. But actually, if you're really going to rely on fluoroscopy, there are some, as you know, some softwares out there that will really help you adjust for pelvic position. So I think there is software out there. And ultimately, at the end of the day, I think we all need some enhanced technology. We've yet to work out how much enhanced technology we need, whether it's fluoroscopy plus, or whether it's a robot, or whether it's some augmented reality. I think we're all heading in that direction.
So, Eleftherios, time is finished.
Time is up. All right.
Yeah,
I'm trying to make the waiting time more interesting, and I think, in summary, we can say that technology is here. I mean, as we move along, the technology will help us to move on, and I believe this is actually, now we see the result. Is not that Olga is less convincing. Actually, her role was very difficult one to defend the older fashioned sort of surgery. And I'm pretty sure she's using or is about to use new technology and robotics. But of course, the emerging data are in favor of robotic technology, being able to combine all this actually calculation into a single choice during surgery, not to mention AI that is coming into play in the near future to help us with the decision.
Yeah.
So,
have you seen the voting?
The voting, yes, this is what I'm describing. That it was
80% vote in favor. So Fares, you won. I mean, then I think, Eleftherios, European Society will invite Fares to a dinner in Thessaloniki, or what do you think, or a beer, or what's
we'll
what's
invite them both. We'll invite them both because they're all honorable speakers, and they're going to contribute to the European Society. They're very welcomed. And of course, the fight was a little bit unfair, but nevertheless, we need to commend them both for their contribution. Thank you very much, Fares. Thank you very much, Olga.
Everything is record. I mean, you are invited, guys. Don't forget that. I mean, we have this record.
Eleftherios is paying. Thank you.
Okay.
Of course, the Greek hospitality is called Greek hospitality.
Okay, let's move to the last part of the webinar. So we have now a fantastic case presentation with 2 questions inside that people should vote. So be ready to vote the best option that you think is correct. And our friend Mattia Loppini from Italy is going to present this fantastic case that probably make us to think about this primary, this simple or standard primary. So Mattia, are you there?
Yes, I'm here. Thank you.
So share the screen and start with the case, and you will stop in a different questions, or you can ask the questions to the speakers, the wonderful faculty that we have here. Go ahead, please.
Okay. This could be apparently older, BMI 29, and she has no comorbidities, no previous spine surgery, or anyway, no spine disorders. She had in the past a proximal tibial fracture in the left leg, managed with a plate and screw, still in the body. She came for a bilateral hip pain in the last 2 years. Both sides, I would say, equally symptomatic. At the physical examination is a significant reduction of range of movement. Favour and Fatih really positive, and there was no limb length discrepancy. And this is she has this type of X-ray. As you can see, quite a severe osteoarthritis, a bilateral osteoarthritis. Also, from a radiological point of view, no obliquity of the pelvis, no apparently regional limb length discrepancy. You can also see the axial view in order to check basically the procurvatus of the femur and also the size of the shaft. So, first question for the faculty could be, what do you think about this case? How do you think is the best management? Total hip replacement, bilateral, just one.
Olga, Fatih, Samantha, Fares, what do you think? I mean, for example, start with Olga. Simple question, right, Mattia?
Yes, just what do you think? If you want to have a more pre-op examination in order to go for surgery or to decide which type of surgery.
Probably Fares said CT, right? Olga, what do you say?
So for the standard procedure, I would not have ask for additional folds, quite enough like AP view, lateral view for the preoperative planning. And for our practice, we don't do bilateral simultaneously, we do just one by one.
Samantha, what do you think?
Yeah, I mean, for someone age 49, my preference would go on cemented, but because of the femoral canals are quite wide here, I would go for a hybrid hip replacement, but I would give her ceramic and polyethylene bearings, and also I would prefer to do them simultaneously.
Wonderful. Fares, CT, right?
Yeah, no, definitely get a CT, assess spinopelvic mobility. Otherwise, I think a straightforward, for me, this looks pretty good for a cementless implant on both sides with ceramic on highly cross-linked poly bearing. And I do one at a time. I think I don't like bilateral surgery, increased morbidity, increased mortality, and this has to be a really good indication for it.
Fatih?
Yeah, same in this side. I would do a cementless poly and ceramic components, simultaneous total hip. It looks like a straightforward case for me. Yeah.
Eleftherios, you are the president. What do you do?
Well, no, I mean, I agree. Uncemented option is straightforward, and I think spinal pelvic evaluation, though, is very important for me, and I do it every time.
Wonderful. Mattia, what do you do?
May I ask you just short or long or conventional stem?
Oh, sorry.
Due to the age. Thinking about the age, you would like to have a
conventional, Mattia. Fatih unfortunately hasn't persuaded me, and the literature's failed to persuade me that short stems have really revolutionized what we do. I like resurfacing, but this is not a resurfacing candidate.
Okay. Okay, I am agree about the literature. This was the question for the audience. Which type of implant? I don't know if the audience.
Can we do the question to the audience? See what they know. They said. Yep. Please vote the best option. Uncemented short stem, uncemented conventional stem, cemented short stem, cemented conventional stem, or resurfacing. So you have seen the comments from the panel. All of them say different things. So you have all options to vote. So we have 7 seconds more. Yeah, wonderful. So they want the uncemented conventional stem, followed by uncemented short stem. So short stem has a role in this patient. Mattia, have you seen the voting from the audience?
Yes.
So continue, please.
Okay, this is my pre-op planning. As you can see, we believe in a simultaneous bilateral case, and we believe in uncemented stem. And actually, although the literature is not showing a real superiority of the short stem compared with the conventional stem, we like to use the short stem if it's possible. I'm agreed that the size of the shaft could be an issue in the decision making. Anyway, I decided for this type of short stem. This was the post-op X-ray, so standard short stem implant with a metaphyseal and proximal diaphyseal fixation. Polyethylene, ceramic and polyethylene has a wet bearing. And this was...
Samantha, you said cemented. But what do you think now? I mean, these nice uncemented short stems. What do you think about this?
It looks good. Let's see the rest of the case.
There's no color there.
You know more than us.
There's no color. There's no color, and this is worrisome. There's no color.
Okay.
No, I was obviously happy for this post-op X-ray, but that's the reason of this case presentation. This was the follow-up 1 month after surgery, and as you can see, we had a subsidence of the left side. It's very interesting that there was the same size of the cap of the stem in both sides, yeah, and also the length of the head. But this was the post-op, the 1 month follow-up X-ray. So my question here for you is what to do? You would like to revise just now, or you can watch and see? And if you decide to revise, do you need to have some preoperative examination other than the X-ray, and which type of revision?
Assuming there is no infection there, it's an opportunity to revise. The stem is going to be removed easily now. There is no reason to wait. And I'm a little bit worried about the other side as well. I'm not sure if it is stable, but definitely cemented stem this time. This is what I would go for. Samantha, I agree with you now.
So,
seriously, Eleftherios, you're gonna now you're gonna fish that up and now cement in there?
Yes.
Wow.
Why not?
Why not just put a stem, that's actually worthy of the fixation and that will hold
Yes.
and then cable the femur around it?
Yeah, it's an opportunity, yes, as well. Yes, you may do that. I mean, I sometimes worry for us about the shape that was given by the previous implant, and I really hope that there is some cancellous bone left behind, but of some sort. It can be, probably with a collar as well. It could be a possibility, but it looks quite wide, and I don't know how much of this canal can be. I mean, of course, a metaphyseal fitting implant may do the job.
Yeah, probably Olga.
I would cement. I would cement. This is my first thought.
So, Olga, in Charité, do you cement or?
No, we are doing a favor of uncemented revision stems. Mostly, probably dominantly, it's like 99% we're going for uncemented stems.
So can I ask about the clinical status of the patient at this point? Is there any pain or any complaining or limping or anything?
She had no pain, incredibly, absolutely no pain. Limb length discrepancy, more or less between 1 centimeter and 1.5 centimeters. So I would say 12 millimeters. And so limping because of the shortening of the left side, but totally asymptomatic in terms of pain.
Interesting.
In the 1 month follow-up visit, thinking that more or less everything was good because there was no pain.
If there is no pain, I would wait.
So let's see.
Wait for what?
Wait for. If there is no complaint, what should I treat? I don't know.
Treat the fact that there's no complaint because it's 1 month post-surgery and expectations are low. It's a young patient, and in due course, they are at much higher risk of unhappiness due to leg length inequality and at higher risk of instability due to the fact that they've lost some of their length. And there is a risk that this fracture may propagate if she has a stumble or a fall. I mean, I recognize the need to treat symptoms, but you have an opportunity before you potentially get worse to do something.
Correct.
I could be wrong. We'll see what happens next.
Yes, Mattia.
Here we have the second question for the audience. So we decide to go in the OR. So which type of surgery?
Okay, let's ask the audience these options. Please start voting. We have the option 1, total revision left total hip, a stem revision left total hip with cemented stem, a stem revision left total hip with uncemented conventional stem, or a stem revision left total hip with uncemented long stem. Can we vote, please? Can we start the voting? Can we see the screen of the voting, please? Okay, thank you. 10 seconds. Okay, I think the main option have been voted is uncemented conventional stem followed by uncemented short stem again. So amazing guys. So Mattia, can you continue?
Okay, so I believe as far as that there is no point to wait, and Okay, this is my pre-op planning. Actually, I didn't have a CT scan, so I was a little bit afraid about a potential fracture. So I hypothesized two different options because I don't know about the shape of the metaphyseal region and the diaphyseal proximal region. So the pre-op planning with a conical stem and a standard conventional stem. And this is a post-op X-ray. So there was no fracture, so it's just a subsidence. There is no change in the varus valgus and antiversion or retroversion of the stem. So I found a proper shape inside the femur to go for a CLS stem, or anyway for a standard conventional stem.
So Samantha, what did you say? I told you.
This is
Samantha?
I say, best to get it right first time. For me, cement it.
Olga, any comment?
No. I found this decision quite reasonable, good. Like your standard, a little bit more longer stem and conventional one, uncemented, really one.
It looks good.
Yeah, Fatih?
But I think it's not so good. Again,
Okay,
that's the case.
No.
Probably something will happen again.
This is the end of the seminar. It should be good.
So, Fatih, any comment?
Did you find anything, any clue why did that implant is subsided? Is there undersized or any reason that you find there during surgery?
No, that's the point. To me, this case is very interesting because at the end of the day, the anatomy and the bone quality of the two femurs should be the same. I put the same implant, the same size, but one of the two sides we had the subsidence. Of course,
it's so easy to extract the
yes, it's totally loosened. So
Faris, any comment?
No, well rescued. I mean, I think it's sometimes the tough decisions are when we get things wrong and we have to fix them. And you've done a good job of getting this patient back on track. Which approach did you use?
Posterolateral approach. Yeah.
So, Eleftherios, close that.
I think it's a valid option. I was wondering whether someone would consider putting a collared stem as well, in case that the fitting was not terribly. It looks snugly fitted, which is fine with me. But maybe also collared stem would probably protect against subsidence. Maybe not.
Amazing.
That's where the world is going.
I still believe that if there are issues with the cortical bone or the fitting of the canal or whatever, people need to be aware of how to properly do third generation cementing technique if necessary. It's not out of the market completely. It is a valid technique. Faris, I think you agree on that.
No, look, I agree. There's still a big role for cementing. I think the issue is if you've already broached for a big cementless stem in the metaphysis, you're really looking at a French paradox type stem, then because you haven't got much cancellous bone left. That's the real concern. But I think it's entirely valid to, cementing should be done in poor bone stock. And if you're in a scenario where cement works and you're used to using it, absolutely. Agree with you.
No, but I also agree. Actually, I decided to not use the cement because of the age. So in young patients, we don't like the cement. And I'm totally agree that the size of the CLS is a huge size for this patient because at the end of the day, we have a lot of fitting also in the distal part of the femur. And this happens if you don't have a real good quality of the bone. But at 1 month after surgery, she was very happy of the right side and the left side.
So, and the case finished here, Mattia, or you have more?
No, this is the end of the case.
Very quick question. I mean, I can see the flare of the osteoporosis over the top of the socket on both sides. Would you go for a screw there? I mean, it's quite interesting to see that the bone is a little bit weak over the top, isn't it?
No,
maybe. But looks like there is a little bit of osteoporosis behind the socket, but this is how the patient looks like. Screws or no screws? Last comment from everybody.
In this case, I didn't had the need of screw.
Faris, would you? I mean, do you worry about this radiolucent triangle over the top of the socket, would you put a screw in this case?
You know what? We routinely put screws in. Number one is training for the fellows and the residents to put screws in primaries, helps them when they do revisions. And frankly, with these days, with modern implants, modern polys, I don't see a downside. So, but I think, these are, if you are used to doing this and get good fixation, it's perfectly fine without. I don't see a problem either way, but we use screws.
I also do. This is why I made a comment, and it's a good practice. It's a good thing to do sometimes. And if you're in doubt, better do it.
Yes.
So thank you, everyone. I'm sorry to always say things about the time, but to be honest, we finished here with the webinar. It was a fantastic webinar, funny as always, and it's because you are great guys, and the environment and the atmosphere here always is friendship. So, Eleftherios, any wrap-up message or any summary?
A great thank you to all the speakers, wonderful contribution, discussion, mature discussion, reality, and sort of objectivity. Thank you very much all.
So, thank you to all the attendees to stay here. Many people from different parts of the world. I have seen some people from Europe, but also from India and other part of the world. So thank you so much to connect with us. You have also available this webinar in a record in the website of the European Hip Society, and I hope to see you next month, 26th. Thursday, same time, 7 p.m. Central European time, with the revision total hip arthroplasty Eleftherios. More fun and enjoy in the next webinar.
Bye, everybody.
Bye.
Bye. See you
Bye-bye.
next
Thank
month.
you.
Bye, everyone. Thank you. Bye.
Bye.
Oliver?
Yes.
Who is actually working on the revision, THA?
I mean, I have prepared all the stuff. I mean, you are involved. You told me yes, right? I invite you and you said yes, correct?
Oh, I thought it was this one. Yes. Have
yes, 26.
Have you sent me the presentation? I mean, is there a title for that?
Yes, I will send you a WhatsApp with all the details. Okay?
Right. Perfect.
So Fares will moderate and you will have one talk. So yeah.
Did I say yes? Okay, that's fine. 26.
Yeah, Thursday, 7 p.m. Central European time.
Okay, I look forward for the topic. I don't know what you want me to talk about, but
I was thinking, I will tell you, I mean, because I have some confirmation left. One of the speakers needs to confirm, but when I have all confirmed, I will tell you your topic. Probably a lecture about revision in the femoral side, but let me check, okay?
No worries, my friend. See you around. Thank you.
Thank you so much.
Bye.
Thank you, all the Clover staff. Thank you so much for your wonderful work. I mean, you did great. No problems. That sometimes is so difficult. So, muchas gracias, chicos.
Nada, gracias a vosotros. Ya está. Ha salido bien, que es lo importante, y a tiempo.
Muchas gracias.
Venga, pues nada, gracias. Hablamos para el siguiente, ¿vale?
Thank you.
Buena tarde, chao. Thank you, everyone.
Gracias. Bye.